Hi, this is Dr. Pedro Ramirez, editor-in-chief of the International Journal of Gynecological Cancer. And today I have the great pleasure of having on the podcast Dr. Angeles Alvarez Secord from Duke University Medical Center, Department of Obstetrics and Gynecology, Division of Gynecologic Oncology at Duke Cancer Institute, and Rob Wenham from the Department of Gynecologic Oncology at Moffitt Cancer Center. We're going to talk about a recently published study, a phase 2 study of pembrolizumab and weekly paclitaxel for platinum-resistant epithelial ovarian cancer. Rob, Angeles, welcome to the podcast. Thank you so much for accepting our invitation to speak to us about this very important article.
Our pleasure, absolutely.
So,
Excellent. So, lots of questions for you on the podcast, and we want to start with you, Rob. Currently, the FDA has approved pembrolizumab with paclitaxel for platinum-resistant epithelial ovarian fallopian tube or primary peritoneal carcinoma based on Keynote B96, a randomized controlled trial comparing the addition of pembrolizumab to the traditional paclitaxel plus minus bevacizumab. So, can you start by telling us what are the differences between your study and Keynote B96 in terms of study design, eligibility, and endpoints?
Absolutely, Dr. Ramirez. Thank you. So both of them really address the question of whether or not adding pembrolizumab to weekly paclitaxel was efficacious in platinum-resistant ovarian cancer. And our study was a multi-center, open-label, single-arm, phase 2 investigator-initiated trial that tested this concept of just weekly paclitaxel and pembrolizumab. And then later, the images and data were reviewed by Merck prior to their development of the Keynote B96, which was a randomized double-blind phase 3 trial comparing weekly paclitaxel with the addition of either pembrolizumab or placebo. And they had optional bevacizumab in there based upon investigator choice. Um, the recent B96 trial that was presented at ESMO 2025 and ESGO and just a couple weeks ago uh, demonstrated that the median progression-free survival for the addition of pembrolizumab, whether it was given with or without bevacizumab, in the intention to treat group, improved the hazard ratio by 27%. And there were similar findings in the subpopulation of the CPS score 1 or greater. In addition, they were actually able to show that median overall survival was improved in the experimental arm too, both in the intent to treat and the CPS greater than 1, and that hazard rate was about 24% improved. The response rate in the Keynote B96 trial and our study were pretty similar between what they saw in their pembrolizumab containing intent to treat population. So they saw about 50%, we were about 46%. But there are some significant differences between our studies. So I would say the differences between ours and B96 is that our study actually allowed patients with one extra prior line of therapy. So we allowed up to 3 prior therapies, and they allowed 2 in theirs. And then, they allowed bevacizumab. And so about a little over 70% of patients in the B96 study ended up getting bevacizumab, and we didn't have bevacizumab in ours. Our trial did also allow patients who had persistent disease after platinum, so they couldn't have had progression, but they could have persistent disease. But B96 excluded those who had progression of disease within a month of their platinum. So in a way, they had a little bit better and more favorable population. Um, and our primary endpoint obviously was different. So we were a phase 2 study, so we did progression-free survival at 6 months, and we did safety as a co-primary because we were testing the waters. But B96 focused on the time to event endpoints like median PFS and overall survival for their groups. But recognizing the variability between these studies, I would say our results seems to be consistent. And B96 we kind of think of as a confirmatory trial for us, and it shows very robust confirmation of that. And so we think along with like Dr. Zeros's data that also looked at metronomic therapy with bevacizumab and pembro, that this is kind of a good support for the use of this, and that the dose schedule and what you pair it with is really important.
Excellent. So, thank you, Rob, for that really excellent introduction. Want to stay with you for this follow-up question, and you mentioned the progression-free survival. as a primary endpoint? This question comes from one of our fellows in the journal, Giuseppe Parisi. He's at the Agostino Gemelli in Rome, Italy. And his question is, you selected 6-month progression-free survival as a primary endpoint rather than overall response rate or median progression-free survival. In a platinum-resistant disease, what makes this the most clinically meaningful benchmark?
Yeah, that's an excellent question. So, in platinum-resistant ovarian cancer, I mean, you can see response rates with shrinkage, but in general, those are short-lived responses with very low PFS. So, is it really a good measure of clinical benefit in this population? We think that, more durable metrics are. And so, PFS 6 months actually captures durability rather than transient tumor shrinkage. And so when we developed our study, PFS 6 was felt to be a better reliable endpoint to assess the efficacy of immunotherapy because checkpoint inhibitors, immunotherapy in general, has maybe less cytocidal, but more disease control oriented. And so therefore, progression-free events are probably better. We also had some concerns about early overcalls of progression and pseudoprogression, et cetera. Um, and in terms of PFS 6 versus median PFS, um, in general, median PFSs have been shorter than the PFS 6 that's been measured in a lot of trials. And so a landmark study or endpoint like PFS 6 is a fixed time kind of metric of durability that's beyond that. It's less jittery than it is for medians and small sample sizes. Median PFS can be unstable in small phase 2 trials and maybe disproportionately influenced by early progression events and censoring patterns, including early discontinuation from checkpoint inhibitor toxicity and pseudoprogression. So we thought that PFS 6 was a clinically interpretable and a stable landmark to look at durable disease control and doesn't depend as much on the exact shape of the Kaplan-Meier curve early on for like medians. Um, in terms of why using 25% as the benchmark historical control, that was based upon what was available at the time. And if you looked at Aurelia, the only thing that had been published in Aurelia was the overall control population. Poveda's report about the paclitaxel only arm had not yet come out at that point. But it turns out that even his report of weekly paclitaxel was 29% on the PFS 6. And by extrapolating on a lot of curves for almost every phase 3 trial that's ever been done, it hovers right around 25% for the PFS 6 value for weekly paclitaxel. And that includes if you just saw Mark Shaheen's paper that was always when the solicitor comes. Sorry about that. If you saw the Mark Shaheen's paper about a month or two ago in Gyn-Onc, where it was looking at real-world data of nab-paclitaxel and weekly paclitaxel, theirs is right at 25% too. So we felt like that was a pretty good benchmark for a PFS 6 for durability to put ourselves against.
Great. So
Can I
now I'll
interject
turn
that
over
really quick?
to
Hey,
Angelos. Yes,
Pedro, can I
Angelo,
interject that really quick? Because I
please.
do want to say, from a historical point of view, too, as well, Rob, some of those decisions were made, a decade ago, right? A decade ago. So when this trial, to go into trial development, to do an IIT like what Rob did, and this was his baby. I just got to tag along. So thanks for inviting me, Rob. But that was probably started, what, 2016, 20, I mean, it's a while ago. I'm aging us right now, but you got approval. We were using that endpoint also based on the data that we had about IO, the concern, as he mentioned, about pseudoprogression. I actually think in this day and age, with what we know about IO therapy and combining it with chemotherapy is the best mode going forward rather than a single agent. I
Mm.
guess my question for you would be, would you use a PFS 6-month time point right now? I'm happy to share my bias with you, but I think that's an important note to make as we continue to develop these trials.
Yeah, no, absolutely, and thank you for bringing that point up, and you're absolutely right. I think that for many of the trials, as we look and evaluate and actually have and develop an opinion about it, of course, obviously, it's always very important, as you said, to think back to what the landscape was like at the initiation of that particular trial, and actually at the development of that particular trial. So with that, Angelos, I'll turn to you and ask, can you highlight what are the results of this study? What would you like the main take-home points to be for our audience?
That it worked. You know, when I was doing this trial with Rob and we were one of the sites, I think I called you, Rob. I think Duke had maybe 4 or 5 patients on. I can't remember now because it's been some time, but I'm like, oh my gosh, every single patient had clinical benefit. There was one patient that had stable disease, which I still think is a potential clinical benefit, and everyone else had a partial response. And on this study, there was one patient who had a complete response. So, you know, the efficacy single, even without me knowing what the data was showing, it was I could tell it was positive that patients were benefiting, and that's huge. And so I reached out to him. I can't remember when it was, but I was really excited. And then when the data came out, and I know we were using a different endpoint, the PFS6 it ranged anywhere from 55 to 59%. And I think Rob did a good job of presenting both the intent to treat analysis as well as the recessed evaluable, and was very conservative on the assessment of that intent to treat analysis as well, because there was 4 patients that dropped out. But the range is very similar. So using even this very conservative assessment for all the dropouts having progression, we still saw that it hit the mark. It far exceeded that mark of anticipation for the PFS6 that was in the hypothesis. And then the objective response rate ranged anywhere from 46 to 51%. And again, when we were doing this, you know, I don't think anyone really knew now in retrospect that weekly paclitaxel is so effective. You know, we know that it's probably about 25 to 30% response rate with just weekly paclitaxel alone. That response rate goes up with bevacizumab. I think in the Aurelia subset analysis, I think it was around 50%. But at any rate, this was pembrolizumab and weekly paclitaxel in patients who were, for the most part, heavily pretreated and had platinum-resistant disease, and the response rates in those two groups were 46 to 51%. So the median PFS, we talk about that a lot, was 6.9 to 7.2 months, which is a lot better than what we see with the traditional therapies, which is about 3 months. And that was a durable response of almost 9 months. And then when you're talking about overall survival, that was really blew me away. It was 2 years, you know, median overall survival. So I was really excited about these findings. And in part, I will say I was skeptical. We actually talked about this, like, we don't believe it.
Yes.
Right?
No, that's
But
true. Yeah, actually, that is so true, I have to say. And
uh-huh,
then,
yeah.
it's funny what you're saying about you getting enthusiastic during it. So
Mhm,
my partner started using it off label at that
mhm,
time, and one of them even published a case report a few years back on a
yeah.
patient during the trial. Yeah.
Yeah, and for the most part, it was fairly tolerable. What I ran into was the neurotoxicity because of prolonged treatment. And so you could drop therapy. So you could, if somebody had an IO-related issue, you had to drop the pembrolizumab, you could do that. And you could also drop the paclitaxel. So, you know, there were patients that I eventually just had to get to a point where I dropped the paclitaxel. But that was in an era before we had cryotherapy and other, you know, that I think does mitigate the neurotoxicity. So big picture is the combination does work. I think there's some skepticism about, well, this just worked because 70% of the patients got Bev, but patients didn't get Bev in our trial, and we still saw a much higher signal of benefit than we anticipated. And then the safety issue that we saw that was surprising was more edema in patients. And I think there's one patient that had pretty significant edema. And Rob, I know you puzzled about this a lot and ultimately came to the decision it was probably the lack of steroids, but we couldn't really find a good reason for that. And then I'll let Rob delve into that further about what it could be. But you know, really, for the most part, patients tolerated the combination. Um, in terms of the overall context, in and I hope we're going to get into that biomarker discussion later, right? But in the terms of overall context, when I'm thinking about the weekly taxane, which is a very active regimen in these patients, I will be unlikely to be using single agent weekly paclitaxel in patients. It's going to be a combined approach. And I think the FDA kind of has limited a little bit of the patients that benefit from this. And Rob and I are really excited about the biomarker discussion, which I know is coming up.
Well, perfect. And I actually want to turn to now the questions from our fellows about the results. And first, I'll turn to you, Rob. This question comes from Nicole Chris at the University of Western Australia. She's asking, PD-L1 expression is reportedly different between primary and metastatic sites in ovarian cancer. Where were the tumor specimens from in your study, and were they all from pretreatment samples or samples from recurrence?
Yeah, so this is an IIT phase 2 study. So you're lucky to get tumor of any kind, as you know. So PD-L1 testing was basically an archival paraffin embedded tumor. It wasn't mandated; it had to be any particular type and time in their prior history. Most were from their original surgery. We didn't specify what site had to be done, whether it had to be primary or metastatic lesion. So that introduces all kinds of spatial and temporal and treatment effects and heterogeneity that you can have in that. And we know, I'm quite cognizant of the fact now that there's been some data that show that the time of storage of samples, as well as like how they were stored, humidity and heat, like that can change PD-L1 staining. So, that's kind of evolved over time. But at the time, people were just like, let's just check a biomarker, and PD-L1 was the one.
Mhm.
Um, but if you think about it, this actually represents the real world scenario. So if you think about how we're doing things right now for somatic and folate receptor alpha and HER2, we're just requesting some tumor and we're staining it. And a lot of people are like staining up front now because of these concerns in case they may want to use this stuff later. So I think it kind of puts it into a real world kind of setting on how you would think about staining for PD-L1. If anything else, it probably makes it more robust that we saw a signal and that B96 saw a signal with it, because it wasn't under just some ideal circumstance of a fresh biopsy.
Yeah. So on that same topic, and I'll turn to Angeles. This question is from Lucia Ribeiro in the European Institute of Oncology in Milan. And she's asking, PD-L1 expression in ovarian cancer appears to be highly heterogeneous. Some tumors express it and respond to immunotherapy, while others do not. Do you think the inconsistent performance of PD-L1 reflects mainly technical issues with its assessment, or that PD-L1 itself is an imperfect predictive biomarker, particularly in the setting of platinum-resistant ovarian cancer?
I think she gave the answer. I love it. I think it's an imperfect biomarker. There's so much heterogeneity. And Rob, I know you kind of alluded to this, but we use that modified score rather than the CPS. So modified proportion score rather than combined positive score. I can't even think of worse acronyms to describe a biomarker, but that was what was utilized at the time. So there's so many technical issues with it. But I think this is a hard biomarker to interpret, maybe. And I also think there's a lot of other biomarkers that are important. So the PD-L1, what it really reflects to me is getting the immune cells into the compartment. And we know with pembrolizumab, we can get the immune cells there. And one of my colleagues, Dr. Gayard, did a pilot study of pembrolizumab. So we found with one dose, we could increase the PD-L1 staining, which means we're getting immune cells into the tumor. And we could also change the stromal interface from being negative to positive. But once those immune cells are in there, we don't know how they're going to interact, right? So it's an imperfect biomarker of what really occurs in that space is so complex. Rob, do you want to add to that? I know you probably some thoughts on that as well.
Yeah, I mean, it's not really, a real oncogenic driver. So I don't think it's been shown to be an oncogenic driver, rather more of a factor of the immune environment. So you can get it from interferon gamma driven expression. It's not really intrinsic tumor dependency that you see with PD-L1. So I think that's why it's been somewhat of an unstable. And of course, ovarian cancer, particularly platinum resistant ovarian cancer, is kind of an immune excluded, immunosuppressive microenvironment. And so, what it means in that environment it can reflect T cell infiltration, myeloid suppression, global immune environment there. But, people have been struggling because we want to have a biomarker, right? Our field, everybody wants to have a biomarker to show something. I think it's great that things work when there's not a biomarker because that just means more patients might get it. But we do want to understand the science. I think this is as close as we've come. There were hints before. I mean, Ursula Matulonis, when she did her study using Pembro a long time ago, found that with high CPS scores, there tend to be better responses. So we know that this is probably just one of many different markers of the immune thing that could be important in discovery to kind of tell us who might benefit more. But as long as everybody benefits some, that's great.
Yeah. So as a follow-up to that, again, still staying on the PD-L1 topic, Giuseppe Parisi is asking, do you think your study may simply have been underpowered to detect a
Absolutely.
potential association with long-term benefits?
Yeah, it was definitely underpowered, right, Rob? It was like
No, it
Rob
was
said, it was
definitive. I
a
think we've
phase
proven it.
it's a definitively underpowered study. I mean, it's a phase two
Definitively.
study, so it's very exploratory,
Mm.
and we were very, very careful in this paper to say that. I mean, it was, as Rob mentioned, it's really hard to get pathology and even to have adequate staining. So I think it was adequate staining in 35 of the 42 patients in the intent to treat group. And yeah, we can, also there's multiple cutoffs evaluated, and I think it was 6 different things evaluated within that cutoff. So if you're doing exploratory analysis like that, I mean, technically, you should take your p-value and divide it by all the different analyses you're doing. And so this was just definitely trying to identify a candidate marker that may give us some signals. And any observed expression with the PD-L1 biomarker and outcomes really is hypothesis generating. I think the other aspects there were, well, the correlative analysis demonstrated associations between the tumor PD-L1 modified proportion score, right, with progression-free survival at 6 months and then response. But then there was a lot of variability, is right, Rob, because you looked at whether it was positive or not, whether it was greater than or equal to 1, or if it was higher than
Right.
1%, and all these
Yep.
additional cut points. But despite this, we were really, we were quite skeptical of the findings. And then B96 came out and showed the improved survival outcomes in patients who were PD-L1 positive. Now, I still have some concerns about that I hope we can dive into. Because when that study first came out and they were saying restrict it to the PD-L1 positive group, I was like, no, I don't think so. Just based on our study, that
Mhm.
we saw so many patients benefit. So it goes back to the possibility that it finds an enriched group that may benefit, but is it truly a predictive biomarker?
Yeah.
That I'm not as convinced.
You bring up a great point that I've been kind of struggling with because it seemed like the approval was very conservative because they did show in the intent to treat that it was improving overall survival as well in B96. But then they looked at the subgroup and they said, okay, well, we're going to restrict it to the subgroup. But to me, in order to use a biomarker to exclude patients from a therapy, you should have data showing that they have lack of benefit, right? If they're included in an intent to treat population and you've shown benefit for the overall group, if you're going to exclude a group now, you probably need to show that they had actual lack of benefit, and it needs to be more than kind of a
Yeah,
hypothesis kind of thing.
Yeah.
But
Yeah.
I agree. But a lot
So
of people aren't doing those biomarker specified randomized trials.
yeah. We're
yes.
going to turn away from the topic of PD-L1 for a little bit and now ask about interval from last platinum therapy. This question comes from Leila Abulazzi in Belize State Medical University in Georgia. She's asking, based on the phase 2 observation that longer intervals since the last platinum therapy might influence response, do you think the timing of prior platinum exposure could serve as a prognostic factor or help guide patient selection for paclitaxel plus pembrolizumab in platinum-resistant ovarian cancer?
Yeah, there's so many things packed in there. I mean, what is the value of secondary platinum sensitivity or, platinum so here's the problem. Every platinum resistant trial always kind of defines their population by a little bit different metric. And so most people concede that 0 to 6 months after platinum recurrence, that's platinum resistant. Okay, that's fine. But does that mean that the patients all went on trial right within 0 to 6 months, or did some of them get progress at 5 months and then at 8 or 9 months they're going on first platinum resistant therapy? Or were they able to receive more than one platinum resistant therapy? Because about this time was also when we started having more platinum resistant therapies introduced. So these patients were recurring 5 months from platinum, but then they would get, single agent Doxil for 5 months, and now they're like 10 months out, and then they're going on trial and they're getting their first dose at 13 months. So you have these kind of complicating factors. So the only thing I could do is just to report it and just say, yes, everybody had progressed within 6 months of a platinum, but because they could get other therapies, because there was these other things, we wanted to look at those intervals and see if they made a difference. Now, ironically, there was no difference between patients who recurred platinum resistant in the first 3 months versus 3 to 6 months. We didn't see any difference there. We also didn't see any difference between those who were getting treated, within 6 months versus those 6 to 12 months. Now, ironically, for the ones who were more than a year, which actually was just a small handful of those patients, I think it was like 15, 20% or something, then, they actually had the opposite thing where they didn't do better. It looked like they did worse because they were that far out. Now, was that because they had more platinum resistant therapies?
That's,
I don't have
yeah.
the answer for that. I think it's just because we were cutting up the data so many different ways that we were bound to find a diamond somewhere within the cucumber. So
Diamond in a cucumber, that's a new one.
that's a new one
Well,
for me too.
so I will share. Really, you just pulled that out. That's impressive. So I will share, Pedro, that I think I was one of the first ones to put on a patient who had intervening therapy or something, and Rob may have called me. And because I think at one point you were trying to keep it a more homogeneous group, but you had to do an amendment to the study to make it more clear. And of note, that patient did have a partial response. So I actually, when I first saw that data, agree with Rob. I thought that the patients beyond that, that latter time period, that it was probably because they did have more therapy. This study did allow multiple prior lines of treatment.
Okay. Now, I want to turn to Alvin Matthew, who's at Houston Methodist Hospital also. And he's asking about other biomarkers. So I'll turn it over to you, Rob. He's asking, besides PD-L1, are there other biomarkers that you consider will be ideal targeted in the future for the platinum-resistant ovarian cancer population?
Well, we're seeing those, but I don't think it's necessarily going to be immune biomarkers, or at least if it's going to be immune biomarkers, it's going to be ones that we don't have currently access to. So, people have tried cutting this up. I mean, for the small population that have really high TMB, we know we have single agent approval of IO for those patients, but how many of those do we really see in ovarian cancer? You can look at MSI high, you can look at dMMR, you can look at these things, but they're not that common, first of all, in most epithelial ovarian cancers. So, other than kind of our evolving landscape of cellular targets that we're trying to do through cell therapy and ADCs and stuff like that, I'm not sure. I mean, we could go through and we could talk about the different immune things that have been kind of looked at to date, but that might, there's nothing on the horizon that I see that's necessarily going to be uh, changing how we do stuff.
Okay.
But the other way to see that, Pedro, don't
Yeah.
you think, is clinically? I mean, just to tack onto that. So right now, Rob already mentioned he likes not always having biomarkers because you can give somebody something right now. And I've heard a few of the comments about, you know, biomarkers. You have to wait. The turnaround time is longer. But from a clinical point of view, PD-L1 is now on the map as a biomarker you want to get, FR alpha, HER2, and then in the future, is it going to be CDH6? We don't know yet. Claudin 6. What about TORL targeting agents for Claudin 6? And then TROP. So I can envision, oh, and there's B7H4. So I can envision a time when you are getting all of these markers up front and you're just going to sequence your therapy based on that. Or if you don't have those biomarkers, the patient comes to clinic, you're going to do a biomarker agnostic approach first because you have it readily available, you go. And then while you're going on that treatment, you're going to start doing the whole biomarker workup.
Yeah, no, I think it's great, and I could already see AI having a role in that selection based on biomarkers as well, and helping us guide that as well. So, Angeles, this question comes to you from Beate Sarta. She's our fellow in Latvia, and she's asking, you thoughtfully discuss steroid elimination as a potential contributor and argue it's unlikely to fully explain the efficacy signal. Looking back now, do you think steroids are more of a modifier than a driver? And has this changed how you approach steroid pre-meds in your practice?
Well, I would say Rob and I've had some nice discussions about this, especially after the Rosella trial read out with relacorilant, right? Because they chose nab-paclitaxel because they could avoid the steroid requirement. And then, as you know, that drug targets the glucocorticoid receptor. So we had a lot of conversations about this. And so I would say theoretically, steroid elimination could enhance outcomes, by reducing glucocorticoid receptor-driven anti-apoptotic signaling that's relevant to taxanes, and by potentially removing immunosuppression that might blunt the checkpoint inhibitor priming. But this gets really, really challenging. I mean, there's a lot of literature about this. And I think, Rob, when you were going through and looking at this, you found a paper in JCO regarding lung cancer patients around the time of this trial was starting that showed that there was worse PFS and OS in patients who received baseline systemic steroids of greater than or equal to 10 milligrams of prednisone or equivalent, and that this has been shown in other recent studies and meta-analysis. So I would say that combined with our study, as well as the Rosella trial, have really intrigued me to think about reducing the dose of dexamethasone when we give chemotherapy and trying to go to like a steroid-light regimen. So there's, there can be a lot of hypersensitivity reactions around, and geographically it can really vary. So I believe there's one paper, Rob, you found this as well. I'm giving you all the credit here, but it was in California that found that, it was feasible to give weekly paclitaxel without any steroids. In our area of the country, the hypersensitivity rate's 11%. So I was pretty nervous about this. So in this study that Rob has, we were allowed to give 10 milligrams of steroids with the first cycle of paclitaxel. And if they didn't have a reaction, then we could continue without it. Because my understanding is, Rob, the rationale for that is that dose of steroid was pretty much negligible. And so if they were able to get through that, they'd probably be okay. So I felt more comfortable. And then we had some other IO studies too where we didn't give steroids. So I'm more comfortable doing it. I think it's an area that needs to be explored. I think mechanistically, steroids are probably more of a modifier, potentially blunting the immune activation and masking inflammatory toxicity rather than a primary driver in tumor response. This whole area of glucocorticoid receptors and their role of cancer, I think has opened up very widely since the findings in the Rosella trial with relacorilant. I am not sure about how, what the future holds. I mean, I think we need to get together as groups and talk about this at our institutions, whether we're going to go with steroid-light regimens across the board. I wish I had a great answer to that, but I don't have a great answer about the why. But it's something that I have brought up with our pharmacist. I do want to make some changes right now, but as a group, we haven't made a change to our pre-medications.
Yeah.
Rob, have you guys made some changes yet?
So I talked to my pharmacist about this, and the problem with making changes like that is you have to make a change within your institution with a lot of people who really have strong, firm beliefs on exactly what HSR prophylaxis should be. But I am wondering now about wanting to really go through and try to minimize steroids for these patients. And we probably overshoot on steroids anyway. You saturate most all your steroid receptors with very low doses of dexamethasone. It has a pretty long half-life. So I think we tend to kind of overdose those patients. But now with this question of apoptosis mechanisms, now with the glucocorticoid receptor, it makes me want to be a minimalist, at least in patients.
Yeah. So, Angeles, I'm going to turn to you again. You mentioned the toxicity side effects. Vincenzo Tarantino from Gemelli, he's asking, given the unexpectedly high rate of edema and the absence of cardiac, renal, or thyroid dysfunction in most cases, do you interpret this toxicity as an immune-related capillary leak-like phenomenon? And did you observe any correlation between edema and treatment efficacy or immune activation?
I'm just going to take that at the very top of that question. That's like three questions in one. But these are all things we talked about, and I think it's really a great observation. So honestly, it was really unclear about the exact reason for edema. Our best guess is that it's probably mostly due to the steroid elimination, but that is really just a guess, right, Rob? I mean, we're talking about small numbers overall. But edema did occur in nearly half the patients, and mostly it was grade 1 or 2. But in the case of grade 3, a full evaluation was conducted, and there was no cardiac, renal, thyroid, or thrombotic causes identified. And the edema did improve after discontinuation, and that individual actually had a partial response after 8 cycles. So, a lot of cycles of therapy there. The rates of edema in the patients taking pembrolizumab with other tumor types that we found ranged anywhere from 10 to 15% in the literature across all grades, and about 1% were grade 3. So disruption of the lymphatic pathways or other factors can predispose patients to develop edema. However, that has not been noted for other studies using pembrolizumab for platinum-resistant ovarian cancer. So we were really, really perplexed about this. So, generalized edema can occur with minimal change disease like kidney or cytokine release syndrome among patients taking pembrolizumab, or so it could be drug or immune-mediated capillary leak-like mechanism is biologically plausible, but it's not really proven. And the studies don't necessarily include cytokine profiling or immune activation to formally test any hypothesis that this is going to lead to differences in biological process or differences in response rate. So, however, we think it's more likely that in our trial it's due to steroid elimination because it really wasn't reported in Keynote 90 and B96, right? So there's something about maybe the patients or that particular regimen that we had. And I don't think we looked at the efficacy connection, did we, Rob? I don't think we did that.
Yeah, no, I can't really recall it. I think for some reason it came up at one point and we didn't really see much, so I don't make too much of it. I never thought about this before, but maybe I was biased in looking for edema because I'd come off of the Trebanadib study a long time ago. I don't know if you remember that, the old Amgen drug that was in
Yeah.
phase one. And I had patients developing all this kind of woody lymphedema. And I was the first one to call them up and say, have you guys seen this in any of your studies? And it turned out to actually be one of the side effects of their drug because it was an angiotensin 3 inhibitor. So I don't know. Maybe I was just looking for it, but no, it seemed to be a real thing. I don't want people to dismiss this. Multiple sites reported it and things like that. So I think it was the steroids. It's got to be the steroids is the only thing that makes sense when you put all this together. So I think Angela's is right.
Oh,
Right.
well, it's, believe me, this was Rob's, us together trying to sort this out.
I want to be respectful of your time. I have just two more questions, and the first one is to you, Angeles. Tell us about the limitations of this study.
Oh, well, there's many limitations. I just think this is a beautiful study. I'm so glad it led to the larger phase 3 trial that turned out to be positive. Just really exciting to be part of that. But any phase 2 study is going to have limitations, right? It's a single arm study. It's an open label study. There was no blinding. We knew exactly what people were getting. Anytime you have these trials, there's going to be investigator bias of who goes on which study and when. There's no central radiology review, but I will share that all these scans were reviewed by Merck prior to the decision to proceed with B96. Rob, can you confirm that? That's my,
Yeah. So no, they requested
yeah.
all that and did it. They didn't tell me what the results of their look over our data were, but they were like, okay, thanks. And then B96 came up.
Which I see as a positive side. There is no central pathology review. I mean, we do know that some of these patients were diagnosed at a time when maybe the understanding of low versus high grade serous cancer, which now seems like so obvious and relevant, right? Maybe not have been as knowledgeable then. And then Rob's already mentioned the use of archival tissue for PD-L1 testing, and then the exploratory biomarker with multiplicity correction that we've already discussed, looking at 6 different outcomes and like 4 different cutoffs, at least 4, maybe even 5. And then the limited capture of molecular covariance. We don't have BRCA1 or HRD status on these patients, must have FR alpha or HER2 new, data. And then limited post-progression therapy data, confounding the OS interpretation. The OS was much longer than we'd ever expect. It was, 2 years, which is pretty amazing. And then incomplete patient level documentation of steroid exposure.
Excellent. So then, Rob, you're the lucky one that gets the AI question. So this is a question that is put together by AI after reading your article. And the question from AI is, given the single arm design and the known activity of weekly paclitaxel in platinum-resistant disease with response rates ranging from 21 to 30%, how can we disentangle the immunotherapy contribution from chemotherapy effect alone, particularly in a population where nearly half the patients were enrolled more than 6 months after last platinum and had a relatively low mean number of prior lines?
I'm glad Rob got this one. Thanks, Pedro.
I mean, we've covered this probably a little bit already. You cannot assign attribution in a single arm phase two trial. However, I will say that I think our historical comparison turned out over time to be a robust one in terms of consistency and what you'd see with weekly paclitaxel alone. I would say that, and that's in terms of our primary endpoint, like PFS6, which is maintained about 25% across the board. The fact that we were, 55 to 59% is fairly good and was well outside the confidence interval bands that we'd expect to see on either side. Our response rate was very similar to the weekly paclitaxel Pembro that was seen in B96. We're right in between both the control and the experimental arm. And so I think what even if it's just weekly paclitaxel with Bev in their control arm that was 73% on their placebo, we're still doing as good as weekly paclitaxel and Bev, or a little bit better than that. So, this seemed to me to be better, and we didn't have better group. I mean, if you look at Aurelia, look at B96, they had two prior treatments. It was fairly restricted. It was a very much we had patients who had up to three prior treatments. Over half of them um, um, had time that they had had multiple prior platinum-resistant treatments too, which just makes them less likely sometimes to respond. So, I would say if you put all that into a big shaker and you shake it up, I think it's pretty good. But like Angela said, we looked at this and we're like, there got to be something wrong with this. Um, but and then B96, I think, is what really kind of gave a pat on the back, like, this was on to something. And I want to give a shout out to MZ Zeros as well, who really was on the same track of metronomic therapy and why pairing the agent is important. I think when we've looked at settings where people just thought you take immune checkpoint inhibitor and you put it with X drug, what you've seen in almost all those studies is you get whatever the response rate is or the response duration of whatever one was longer. So, they did that with Merv, right? So they did Merv and Pembro, and then they saw that there was about 30% response rate, which is about what you get of Merv. And you do that with Doxil, and you get about Dox. So you got checkpoint inhibitors with 7 to 9% response rates, and you've got single agent chemotherapies that are not much better than that. And so just putting those drugs together, if there's no reason for them to interact, we're not seeing anything. But if you have a plausible mechanism by where they can help each other that you see with metronomic therapy, and that's where I'm giving, MZ a shout out here. She saw that coming too. And quite frankly, I like her metronomic Cytoxan regimen in terms of tolerability. But I think both of these plus the B96, when you put three trials together, it's just a lot of weight.
Yeah. Well, I want to thank both of you. Fantastic discussion. Really, again, very, very exciting finding. And again, a proof to the fact that all of these trials are so, so important for the treatment of our patients with gynecologic cancers. And thank you both for the contributions you've made to the field of gynecologic oncology. And I know that our audience cannot see you because obviously there's just audio, but I do want to guarantee that you two are the both the best dressed podcast interviewees that I've ever done on this journal. So thank you very, very much.
Well, I'm just following Rob's lead.
A pleasure to be on here, and I really appreciate you highlighting platinum-resistant ovarian cancer and letting me talk with somebody as bright as Dr. Secord. So,
Thanks, everyone. Thank you so much.
you guys take care.